Hi, Mike Gibson and Bill Lombardi coming to you live from the SCAI 2015 meeting here in San Diego. Bill, talk to us about CTOs. First of all, for our audience, tell us why treating CTOs is important.
Well, I think one of the challenges has always been about complete revascularization. And we talk a little bit about myocytes really don't know why they're ischemic. We've learned a lot from the FFR data that the angiograms don't tell us what's ischemia. It's really the physiology. And so CTOs are just another lesion subset that develop ischemia. And so what we're trying to do is eliminate the angiographic criteria of revascularization and really base it on physiology, similar to what we're seeing with FFR. And historically, because of the technical difficulties in opening CTOs, it's really limited our ability to do any data or research or to really evaluate a benefit that we're getting.
Because the sample size is so small to answer the questions, right?
And you have to have such angiographic exclusion criteria that you can't really get a big cohort. And in an intention to treat methodology with a success rate less than 70%, we really couldn't design an appropriate study in that situation. So it's become a chicken and the egg is, did we need the data to show us we could do it, or did we need to show we could do it so now we can get the data? And the way that this has really evolved over the last decade, it's really we've shown we can do it, and now we have to start working backwards of really getting better clinical data to show who's going to get the most benefit and how do we do that safely and effectively.
So what is some of the data, albeit maybe not randomized, but observational data or retrospective data that says opening a CTO gives you clinical benefits?
Well, there's sort of two ways that I would look at this. One is if you look at the surgical registries, so there's a couple of big registries that have been done, and the biggest predictor of a patient being referred for bypass surgery, interestingly, is not a left main lesion, is not three-vessel disease, is not low LV function, and is not diabetes. On multivariate analysis, it's actually the presence of a CTO.
Wow.
So it's very interesting is that we have that preponderance to refer them to surgery, but when you end up in a PCI arm, we tend to treat them medically, which has a little bit of an inconsistency in sort of the physiologic concept. So from there, when we look at the data, there's been a couple of meta-analysis now looking at success versus failed CTOs, and unfortunately that's all we have. There's been a clear benefit on symptoms benefit if you're successful. And then the meta-analysis, there has been a mortality benefit of success versus failed. The most recent was the BESIS data, which was published last year, which was 14,000 patients from the British Cardiac Intervention Survey, about 10,000 successful and 4,000 failed. Again, about a 70% success rate, mimicking what it's been historically. And what they showed was a 28% reduction in mortality of success versus failed at 2.65 years. And interestingly, in those 14,000 patients, the curves continued to diverge at 4 years.
So it wasn't an early benefit or a result of complications early on.
That's our supposition. Unfortunately, as we know, registries and things have their things, but that's our supposition, which has led to what we're moving on to now, which is the open CTO registry. So this is a 10-center prospective registry in the United States looking at consecutive patients referred for CTO at high volume centers. It's core lab adjudicated as a DSMB, and we're looking at a lot of procedural outcomes, quality of life metrics, and then cost effectiveness data. Aaron Grantham, myself, John Spurtis, and Dave Cohen are intimately involved in the design. And we'll look at this, and this data will close. We should have our 1,000th patient enrolled in just about 18 months, and that'll be June, and we'll hopefully have 30-day data to present at TCT this year to help get more information on this.
So we have the appropriate use criteria now. Who is the appropriate patient for a CTO opening? So
I think when we talk about it, there's my understanding is the appropriate use criteria are going to eliminate the angiographic downgrades that CTO has had. And they're actually going to eliminate CTO from the AUC. So it just would go back to single vessel disease. But previous to that, really the appropriate patient is the same as someone in my book that would have a 90% lesion. So you're looking for people with symptoms and an area of myocardium that's subtended, that's a large barrier of ischemia. And you want to have them on 1 or 2 drugs at minimum. And so really it's sort of taking the picture out of it and choosing the right patient. That being said, a lot of these patients have a somewhat different symptomatic presentation. And I think this is one of the things we need to learn more about from a registry is that chronic ischemia is a different animal than more of the acute events that we don't, I think, understand as well as we'd like. we see a lot more dyspnea and a lot more fatigue in these patients than we've seen in sort of the classic anginal patient. So it'll be interesting as we get more data is whether we have a better understanding of who really is appropriate.
Interesting. And what do you see in the future? I mean, are there any kind of game changers you see coming down the pipe?
Well, I think, unfortunately, right now it's still a really hard procedure. We've made, with the hybrid algorithm that was published 3 years ago and with some of the new technologies, we've seen it becoming easier to learn to do this. The anatomic challenges are slowly improving. And like anything, now that there's more success and more clinical interest in it and there's more industry support, so we're seeing technologies now being brought to bear and more industry involvement to help us develop new technologies and tools to simplify the procedure, similar to the way angioplasty started. You know,
right.
when we had a balloon on a fixed wire, and then we got over-the-wire systems, and then monorail systems. So I think this is hopefully where we'll see move forward. I think for the next few years, really the challenge will be in education. And I think SCAI is going to be intimately involved in that, where we really look at practicing interventionalists and how do we find newer and better ways to teach people complex techniques who have to live under the realities of being in clinical practice and getting their work done.
Do you think we might see a day dedicated to CTO here at SCAI sometime in the future?
Yeah, I think we will see. You know, many of the major meetings now are having an increased focus and sort of a
a day dedicated
a tract like we have here. And so I think we may see at SCAI this evolution where the CTO becomes part of the coronary tract, where we see more dedicated education and trying to do it, because a lot of the skill sets from CTO actually transfer back to non-CTO, and I think that just makes us all more a complete interventional cardiologist.
Yeah. Absolutely. Bill, thanks for coming by.
Thank you very much.
Thanks for joining us here for SCAI 2015 from San Diego.